Well, why don't we get started here? So let's go and talk about marrow and immune origin diseases here. So here's the first case.
Okay, so I have a 32-year-old female, palpable chest mass for 1 month, and we have the ultrasonogram images where just below the level of the subcutaneous plane and musculature, we see a fairly defined hypoechoic lesion with some areas of cystic component, which is really vascular on the Doppler images. And on the MR images on T1, it is predominantly ISO intense to muscle on the fluid saturated, and the PDFS images, it is very, very bright. Okay, so Castleman's disease. Okay, but without the lymph nodes?
Well, this is probably a large lymph node.
Okay, that's a large lymph node. Okay.
Yeah. So this turned out to be Castleman's disease. So it's Castleman's disease.
I'm not quite sure, but there is a lot of lymph node proliferation in this. That's all I know about Castleman's disease.
So it's basically benign lymph node proliferation. I don't think anybody quite knows what the cause is from it. It can be pretty concerning. Maybe it's a low-grade inflammatory process, but it's usually self-limiting. Okay. Dan, what do you think of this case?
So we got a 75-year-old female. That's it, and then we have we have multiple axial images of the knee where we see kind of like a multilobular cystic structure posterior to the vascular bundle, kind of posterior to the artery and nerves. Either I'm thinking about this could be a kind of like a atypical lymph node. Yeah, if the patient has like some sort of bug bite or some sort of infection distally.
Are you getting bugged?
I don't know. I said bug bite. I had a patient with a bug bite actually recently here, and then the patient was treated with antibiotic and got like a Achilles tendon rupture, but that's a backstory. Yeah, bilateral actually. 2 doses of levocoin, bilateral Achilles tendon rupture. I want to show you guys later. But this one on the ultrasound looks like there is some vascular flow. Centrally, it looks like a lymph node that's enlarged. And
yeah. So
what does that mean? I don't know what that means. Neural.
It was really lymphoma involving the nerve. What that was. So this is a lymphoma involvement of the nerve. Okay. Jeff, what do you think of this case?
14-year-old male, multiple palpable masses in both calves, an ultrasound, 2 ultrasounds, and we have a hypoechoic lesion in the subacute tissues with some through transmission.
Okay, I just need to check something here because evidently Dr. Yagutis, just 1 second here. I just want to check to make sure that I sent Dr. Yagutis. Yeah, Yagutis, it was sent. Okay. I don't know what. Alrighty. Okay, I'm sorry.
So, yeah, so multiple palpable masses of both calves of a basically a hypoechoic fluid, basically like a fluid collection looks like, or a complex fluid collection possibly, with there is some vascularity associated with that, at least one of those foci there. So we have axial. So we have axial images of both calves, lower extremities, T1, T2, stir, and maybe post-contrast. Not sure, but and we have looks like especially more on the left side, you can see these T2 hyperintense lesions, multiple lesions there. Looks like, and there is probably some enhancement associated with them. So again, some vascularity. And
so John, thanks for joining us. And we're kind of right now looking at inflammatory or lymphatic type disease. Okay.
So it's kind of non-specific. I mean, at this point, they're kind of scattered there. They might, again, and on this T1 coronal, you can see also see it in the left calf as well. This T1 hyperintense area,
so
and then
multiple areas
multiple areas here. So this, and these look like it looks like on the ultrasound, looks like a fluid collection. So
it doesn't look like a fluid collection on the MR, right?
No, it doesn't per se. So again, this could be some kind of, so now we have a axial CT. We have a very lobulated mediastinal hypointense mass in the mediastinum. I'd say, given this presence, we have some type of lymphomatous proliferation, and in the calf, chronic inflammation organizing abscesses. Okay. So it's actually those possibly were abscesses. Those were like a fluid collection type structures there.
They really don't look like fluid collections on the MR examination. So
does that have excuse me, John? Does that have anything to do with the thymus? Or I may be off my base here, but I don't know.
It might have come down from the thymus. That's possible, or you could even have a mediastinal thymus that was involved with it. So it's possible.
Yeah, I had a patient that a doctor's wife that died of the condition. It was kind of miserable.
Yeah. Okay.
Oh, anyway.
Yep.
Happy Thursday.
So here's an 81-year-old male with a left upper arm mass for 2 months. 5 months ago, there was a 1 centimeter mass. It was excised and recurred, doubled in size in 10 days. That's pretty quick. Geez. So here we have a photograph of the patient's arm with this kind of fungating mass lesion kind of at the cubital fossa, and there it is on radiographs. We see the soft tissue swelling out anterolaterally. Not seeing much for involvement of the underlying bone. So it's intermediate hypointense on T1. Presumably it is enhancing, especially in the center there on our fat-sat post. Of course, we always do want to compare like to like. Here it is on T2, intermediate high with that more focal area of hyperintense signal. And yeah, there it is kind of bursting through the skin surface there as well in the sagittal. Well, this would be concerning for something like skin cancer, like a melanoma, perhaps.
Yeah, it would be a little bit odd for melanoma. It didn't really look like it had melanin in it on the X-ray. They tend not to be quite well. They can be large and focal like this, but usually we catch it long before this, and usually their growth rate isn't so rapid.
Yeah, this was quick. Okay, well, here we are with sort of this diffuse invasion of the left kidney. Now, looking at this and the other lesion, I mean, the way that this sort of effaces but isn't really compressing much, I mean, this is more of a behavior of a lymphoma type lesion. And okay, and then that was a skin. Oh, okay.
Okay. So, with lymphoma.
Jeez.
Good. So let's move on to the skin then.
Okay, so it's a 38-year-old male with left thigh mass, and we have ultrasonogram images. So kind of see that lobulated lesion just in the subcutaneous plane with no vascularity as such within it. Okay, this is an epidermoid inclusion cyst. Okay.
So this just has a lot of internal signals. This is most of the epidermal inclusion cysts I've seen. Sometimes they can be a little bit onion skinning like this, but this almost looks like more of a solid type mass. But, okay, Dan?
We got a 4-year-old male with pretibial mass for 2 to 3 years. So it looks like we have distal to the tibial tuberosity, we have this kind of complex, I guess, multi-molecular fluid collection in the subcutaneous fat. On the MRI, it just looks like, it's pretty well marginated, and it has like fluid inside and some posterior acoustic enhancement. So I'm worried about, again, some sort of like, a benign,
So this is calcinosis cutis. So these are almost always calcified on plain radiographs. Yeah. And it's a benign.
Sorry, is that like sort of like bursitis or? I don't know what that is, calcium.
I don't know what the histology on these are. They're benign masses of the subcutaneous tissues. They tend to be calcified. My guess is that they're probably from trauma and maybe old hematomas, but I'm not exactly sure.
John,
yes.
If they're calcified, why is the one on the right? What kind of image is that on the right?
This is a T1 fat sat post contrast.
But I thought calcium would be black all around, but I guess.
Well, I think there are areas that are probably calcified within it, but this also has a lot of soft tissue with it, which is probably showing some peripheral enhancement.
I got it. Okay, I just wondered.
Yeah.
Dr. Cruz.
I'm kind of a wondering kind of guy.
Good.
So for this case, like, I mean, as we said, like trauma, so then if it's a trauma, can we put like Morel-Lavalley kind of lesion, kind of like more like a shear injury to the anterior?
Yeah, a Morel-Lavalley injury would be, you would have to see fluid and you have to see really a separation at the deep fascia of the skin.
And a lot of fat and blood. But this doesn't look like any of that.
This potentially could be a chronic lesion later on.
You mean like
a coma?
A contusion maybe, but not Morel kind of a.
Yeah, this wouldn't be the acute. Morel-Lavalley is really the acute phase where you have fluid, we have separation at the deep the deep part of the dermis, which separates from the underlying tissues, and you get hematoma formation there, and you've got blood typically in that area. This might be something that's more. This is more really within the subcutaneous fat. And my guess is that these are post-traumatic, but I don't know that anyone's actually proven that.
I wonder if anybody's ever researched to see a 4-year-old having a Morel-type lesion. I
don't know.
I would imagine a contusion with a collection of blood, a hematoma could produce this kind of a picture, but Morels don't go away, and that I know of.
Yeah, but see, this is really centered in the fat rather than at the interface between the deep fascia.
Well, this is going right to the periosteum, isn't it?
From periosteum to the epidermis, right?
Right. Yeah, this is a strange area to have. Morel, there's nothing there to cause that. But anyway, I'm sorry to interrupt you. It's kind of a.
Thanks, John. Thanks, John. Jeff, what do you think of this lesion?
68-year-old male with a growing mass, and we have axial images. It's just this looks like the femur. So it looks like a subcutaneous mass that's T1, a little bit of T1 hyperintense to the muscle. It's pretty well circumscribed. And
what are the T1? What does T1 hyperintense to the muscle imply?
Well, there might be some maybe mesenchymal or something type of origin, or maybe a little bit. Well, it's not. Well, I'm thinking along the lines of, or maybe.
What's bright on T1? That's what I'm asking.
Well, fat is, fat. Hemorrhage can be fat.
Okay, so I guess this is
hemorrhage, protein.
Hold it. Let's start with fat.
Yeah.
Okay, if this is fat, then it really doesn't look like a lipoma, but I guess it could be a liposarcoma. So you'd have to think about that. What else could be bright on a T1?
Again, hemorrhage can be bright.
Okay.
Proteinaceous material can be bright.
It doesn't really look like a hematoma, but there could be some hematocytic parts in it. Okay. There could be a proteinaceous fluid, but this really doesn't look like a cyst. It really looks like it has some solid elements in it. What else can be bright on T1?
Melanin?
There you go, melanin. So melanomas often are a little bit brighter than muscle without being really bright. So I certainly would be very concerned about a melanoma in this particular case. So that's good. And now there's some inhomogeneous signal intensity on the T2 weighted images, and this was a malignant melanoma.
Oh,
good.
Okay. Oh.
So by kind of going through the differential with the signal characteristics, it really can actually be helpful occasionally. Not always, but sometimes. Good. Okay, and let's go to lesions of uncertain origin.
Okay, so I guess here we have coronal T1 and STIR images of patients, I guess lower leg near the knee. And kind of along the lateral aspect of the proximal tibia there, we see this area of intermediate hypointense signal on T1 and avid hyperintense signal on T2. Okay, here's a couple.
This isn't T2. This
or STIR rather. PD fats out. Yeah, sorry. Yeah, PD fats out. So okay, here's our T2, and it's an intermediate kind of signal there on the right. Intermediate hyper. There's a little bit of irregularity of the adjacent cortex. So there's perhaps some, at least cortical. Well, it's more intact there, though. That could be an artifact on the T2. Maybe a little cortical thinning there on the axial, and I see this one area of kind of cortical discontinuity right in there, but it's probably okay. And probably, yeah, the marrow space looks pristine, so it's not really locally aggressive or invasive. I mean, it's kind of just expanding into the soft tissues there. It's a little bit too high signal for some kind of fibroma.
Okay. And polycancer neural tissue, but it's put in the uncertain origin because people still are arguing over the origin of this particular lesion.
That anterior compartment looks like the muscles have had some atrophy and fat infiltration. There must be something going on with the perineal nerve.
I'm not sure. Yep. Okay, so. All right.
Okay, so a 61-year-old male with a 4-year history of leg mass, and we have a couple of sections of CT in corneal and sagittal planes. So we have a very hypodense, perhaps cystic area, which is involving the anterior musculature. I think probably that is vastus medialis. The posterior.
I think we're in the
gastrocnemius. There are no nodules or anything. We have pre and post contrast images. There is no enhancement. There are no nodular components. It does not infiltrate into the muscle. It's very, very well defined. Likely to be a benign cyst.
No.
It's not benign.
Don't say that. No, not in muscle. Benign cysts in muscle are extremely rare.
So, okay, it's a myxoma, the most common cystic area in the muscle.
Yeah, and myxomas typically, for things that look like cysts in the muscle, muscle tears, common things that you see, muscle tears, hematomas, and things like that don't look like this. Mm-hmm. They're much more regular, with edema kind of going out in the soft tissues without sharp margins. If you see a sharply demarcated lesion like this that looks like it's cystic, mm-hmm. and in the muscle, it's almost always a malignant myxoma. Okay. So these are malignant. They're not very aggressive, but they're potentially malignant lesions. So you got to take these very seriously. But they look both on MR and CT. They can look like cysts.
And they don't enhance on contrast.
They very often do not. Almost all the ones I've seen have not enhanced on contrast. Sometimes you can get a REM enhancement. Occasionally you can be lucky and you'll have a little nodular enhancement within it. But usually they look just like that. Dan?
Okay, we got a 50-year-old male with an incidental finding. Looks like on a CT exam, they saw some intramuscular mass where they actually got, I'm sorry, with the MRI. It looks like, I'm not sure if it's like a subscap, but it's like lower, maybe. I'm not sure what would be the latest anterior. I mean, it looks like a subscap on the sagittals.
Okay.
So it looks like we have this kind of like a hyper intense mass on the post contrast images, has like more heterogeneous enhancement, actually central enhancement. So I'm worried about malignancy or and then the pathology. I don't know if that would help, but it looks like it's well circumscribed, but the internally is a little heterogeneous, and it has septa. So my guess would be one of that could be Synovial Myxoma again.
Yeah. So that's another Intramuscular Myxoma. This just shows that sometimes they can have internal characteristics. But here, the things to think about would be potential hematoma. But again, they have a sharply circumscribed lesion like this within a muscle. The benign things and hematomas and so forth don't tend not to stay around. So you really have to, whenever you see a mass like this in a muscle, you have to be very concerned about myxomas.
And I was also worried about, like, maybe like synovial sarcoma. Would that also be in differential? I know those are more common, like in the lower extremity.
Synovial sarcomas can be anywhere, and we'll see some in a minute. You can certainly include that, but it's uncommon for them to be within a muscle. Usually they're next to a muscle, but it's certainly reasonable to put that in the differential. So, and they can have a little bit of fat, and then occasionally you can also get myxoid liposarcomas with a fatty element in it. Okay, Jeff.
Okay, so we have axial T1 or T2 of the knee. We have the T2 fat suppressed coronal and maybe T1 or this is T1 sagittal images. Looks like there's a mass within the looks like Hoffa's fat pad of the knee. It's septated. It's T2 hyperintense, T1 hypointense. Looks like the cortex of the adjacent tibia appears to be preserved. I'm saying tibia, the femur appears to be reserved, and it looks like. So I would say right now, actually, you mentioned synovial sarcoma. I mean, that's probably, it could be in a differential. This certainly can't exclude okay,
you can do that.
A malignancy.
Now, just remember that synovial sarcomas have nothing to do with synovium. They're often around joints, but they're generally not connected to the synovium. So it's really a misnomer. Now, in a situation like this, most people, could this be a ganglion cyst? Well, this is actually a true T1, and a cyst should be lower in signal intensity than this. We can see septa in it. It's kind of sharply marginated. So the other thing that you have to worry about is for soft tissue tumors that look like cysts or myxomas. And this was a myxoid tumor that was malignant involving Hoffa's fat pad.
Okay.
So there are very characteristic locations where we see ganglion cysts. If you saw this here, you would just always say that it's a ganglion cyst. You might not even think about including it in your dictation because they're so common there. But they're not common as masses in places like Hoffa's fat pad. That's not where they occur. So when you see something that looks like a multiseptated cyst in an area where you really don't see them typically, then you have to start being concerned. And this was a malignant myxoid tumor. It was non-aggressive, and I think it was treated well with excision, but it still had malignant characteristics on the histology.
Okay, so here we have a 71-year-old female, and roll out right lower extremity venous insufficiency. Looks like we've got DVT study, and it does look like there is this kind of heterogeneous sonographic, yes, it's mostly hypoechoic, a little bit hyper debris within the vein there. Okay, however, while this appeared to resemble a DVT in the prior image, there seems to be internal flow within this debris, which raises, oh Jesus, concern for a mass, which I think we're dealing with here. This is a large heterogeneous mass with a lot of mass effect, perhaps locally aggressive. I need to see a couple more cuts. You know, we've been talking about Synovial Sarcoma. Perhaps we could be into that. Okay, so let's see.
So it's very large.
Very large, massive, yeah.
Concerned, right?
I mean, I think this is
very inhomogeneous. That also makes you very concerned. It's here we can see it's actually involving multiple compartments. That even makes you more
especially concerned. So like
this was
okay, it is. Okay, yikes, that's crazy.
Yeah.
It's the same case, which is like.
That's okay. That's after surgery, so they did an amputation.
Unfortunately, there was no way out for that lesion.
Yeah, it's too big and involved too many structures, including surrounding some of the neurovascular bundles.
There's no way to dissect the whole thing out and not leave something behind. So these are the unhappy situations that orthopods run into. I hated amputations. Unfortunately, I did quite a few of them, and because in my day we didn't have the vascular surgery techniques that we used to, that we have now. So it's
yeah, great. Thanks, John.
Dr. Cruz, in the previous case, was that tumor like arising from the venous wall or someplace other?
I don't know where it was arising from,
okay.
And I don't think anybody else does either, because nobody really knows the tissue of origin of the synovial sarcoma.
Okay.
That's why it's under the unknown origin category, so we don't know.
Okay, for next case, a couple of images in sagittal plane, T1 and perhaps T2. So kind of hypointense mass on the T1s, around the navicular, the cuneiforms, kind of eroding them. Very well-defined margins and appears hyperintense on the T2 images. Not quite sure where to put this, but synovial sarcoma, since you're starting the topic.
Yeah, it's near joints, but this, yeah, it turned out to be a synovial sarcoma. And remember, it's 10% of sarcomas, so it's one that you will see. Okay, Dan.
We got a low field study. Looks like two axial images.
Actually, this is 1.5T.
Is it 1.5T? Oh, maybe like an old technique.
1988.
1988. All right, fair enough. So this, we have this kind of like a large mass in the region of the ilioischial, like interval. Huh? Yeah, it's basically like there's like a mass in the near the adductor muscles, kind of extending posteriorly. I'm worried about again another. So on the coronal images, it's just like kind of heterogeneous and probably has some necrosis with the low signal. Again, another maybe a synovial sarcoma.
So this is a T1 weighted image.
So it's like more proteinaceous. I guess it could be fat or it could be some blood products. Melanoma, I mean, less likely.
Yeah, melanoma wouldn't be this bright. Melanoma's not that bright. So this, I'd really be concerned about blood. So this
Right.
looks like a hematoma,
Yeah.
kind of bright around the edges with a dark center in it.
Yeah.
So a lot of mass effect here. So this is really a hemorrhagic mass.
Yeah, I would worry about the hemorrhagic mass.
Both sides of the joint, which is
Mhm.
something that's kind of characteristic of this particular lesion, in large part because it probably grows through across compartments. So what do you think it is?
I mean, for a hemorrhagic mass,
Yeah.
I would worry about synovial sarcoma. And then also, I mean, I don't know if other metastatic lesion could cause that, like the muscle, but it's unlikely.
I guess it could. Yeah. There are some vascular metastatic lesions that I guess could have hemorrhage like this, but this is fairly typical of synovial sarcoma. Hopefully you pick up mets before they're this size. We'd like to pick up the synovial sarcoma before this size too.
Do they spread lymphatic or venous, John, or both?
I don't know.
I'll have to look that up.
Yeah.
I've never checked that out. I don't either.
So these are classic, have hemorrhagic foci. If you saw that large one that we started with, that fluid levels within it, those are hemorrhagic, basically hematomas within it. These are very vascular lesion, which is why they get that way. And it's common for them to have fluid levels due to the hemorrhage within them. Okay. Jeff.
65-year-old female with a knee mass, radiographs, frontal and lateral views. I think really
we see a lot of degenerative bone disease here, but
yeah,
showing this because of bone disease. Maybe there's fusion there. So let's see what else happens here.
Can you go back, John? What would you tell your radiology tech about this X-ray?
I don't know.
I would tell him I got a better one.
Yeah. Well, this is what we have. Yeah, it's going down a little bit, but we'll see in a minute. Okay, so this is first X-ray. There's the ultrasound, and then we can see the bone scan. What do you think of the bone scan?
Well, now the bone scan, there's asymmetric uptake in the left knee, distal femur, maybe proximal tibia as well.
There's the MR.
Okay, so now we have sagittal T1 images, or is that the second one on the? I'm not sure. That's T2 maybe.
T1 and T2.
They are T1 and T2. So now we're looking again in Hoffa's pad, because it's almost kind of like I saw earlier. Is again this T1 hypointense lesion, also T2 hypointense, with fairly well circumscribed Hoffa's pad. And
okay.
I mean, last time we described a type of myxomatous type of tumor
but this
in that area.
This isn't myxoid, right? Myxoid would be bright on the T2.
That's true. This is hypointense.
This goes all the way posterior compartment.
Well, we know that, yeah. And we know from the radiograph there's no calcification in that area either that I can recall, or was there?
Well, again, I think, as John was saying, we really don't have really good visualization. It's hard to say. Okay, there's that. Here are the axial images.
So axial, let's see, PD fat sat images, and is that post contrast or maybe not? So
to be honest with you, I don't know whether this is post contrast or not. It might well be.
Okay. Yeah. So I mean, I think it's again we're seeing this kind of similar information. We have.
So assume this is T1 post contrast, and this is a PD fat set.
Okay. So possibly some enhancement.
Yeah,
peripherally within it.
Yeah.
Yeah.
Okay. So this was a
clear
cell
cell sarcoma.
sarcoma.
Okay.
And this is kind of associated with Ewing's in the sense that they're both from the same gene. And sometimes this is very hard to differentiate between this and melanoma. Okay.
So this is a 16-year-old female with a soft tissue mass. We've got coronal T1 of, I guess, the posterior thighs and axial T2, same area. And what we're seeing is this multiloculated intermediate hyperintense structure rising from, well, or at least within the hamstrings. Okay, so it's quite expansile and it's quite large, so this is concerning for malignancy. It doesn't seem to be locally that aggressive, and okay, I assume that we're showing some enhanced.
It's growing within that compartment fairly aggressively.
Mm-hmm.
A lot of mass effect.
Yeah.
The margins are fairly sharply defined.
But I'd still be quite concerned for malignancy, and now she's got lung mets. Let's see, 1, 2, at least 2. Soft tissue. Okay, gotcha.
Okay.
Interesting.
Okay, so for next case, a 29-year-old with a slow-growing mass, I have T1 and perhaps PD fat site images, which...
I think these are both fat site.
Both fat site images. All right, so I see is it within the acetabulum or femoral head? Yeah, femoral head. So the femoral head is completely replaced by that lobe.
I think we're in the soft tissues. I think these are all soft tissues.
Is it soft tissue? Okay.
I think we're anterior to the femoral head.
Okay, so within the soft tissue, we have a very well-defined, rounded, multilobulated lesion with so many septas, kind of heterogeneous signal within it.
Yeah, this is probably PD fat set, and this is probably T1 fat set post, I think.
Okay. So
Okay.
on the axial images, I don't see any fluid levels as such within the lesion. It's entirely within that muscular compartment. It's not infiltrating elsewhere. Our patient is young, but I still would be concerned for malignancy in this case. Oh, okay, that was wrong. Soft tissue aneurysmal bone cyst. But it's within the...
Something you see every day. Histologically, it looks like aneurysmal bone cyst.
Okay.
And again, we can speculate what these are. Aneurysmal bone cyst, some people believe may be chronic interosseous arterial side hemorrhage, which then causes expansion of the bone. And maybe this has something to do with vessels as well. But the histology looks like the same histology as in aneurysmal bone cyst. It's just not in the bone.
We wouldn't call this a myxoma by any chance.
I think you could put that in the differential.
Okay.
Yeah, but I think that this would be a pretty wide differential because there's a lot of soft tissue components to this. And it is odd that that we're not seeing fluid levels, but I would expect to. Okay, Dan?
So we got a young woman with joint stiffness. We got an elbow x-ray. We have multiple kind of like linear calcification throughout the soft tissues. So I'm worried about, like, again, a parasite disease. Looks like everywhere.
So what parasite?
Ones that's it's in Brazil.
Okay. Well, we were thinking about whether we should eat pork for lunch today or not.
Cysticercosis.
Cysticercosis. I mean, that would be like neuro, but I guess cysticercosis, yeah.
Yeah, cysticercosis. So if you ask why some religious groups and some people don't like to eat pork, this may be the reason. So just make sure it's cooked. Okay. Yeah, so that's the classic appearance. And some people call them rice grain calcifications. And this is just kind of the anatomy of the tedium soleus. Okay, I guess that's a kind of overview lecture for soft tissue tumors. if we have time later this year, we might go into some more details. But so why don't we stop here, and then tomorrow we'll take up lumbar spine. Okay? Does anybody have any questions?
Dr. Cruz, what do we do for those calcifications, or we leave them alone?
There's nothing you can do for the calcifications. Oh, well, I guess you can go in and resect them, but nobody's going to. The damage would be too great. So if you think there's any active disease, I think there's medication to kill the cysts, but they didn't calcify after they die. So all of the calcified cysts are all dead.
Yeah. And so there is no concern for future fibrosis or scarring?
You can check into it and see and let us know, but not that I know of. All right. Thanks, everybody.